All right, welcome back to the deep dive. When I think about the skills that really make nurses stand out, there's one that always comes to mind. It's an amazing ability to piece together the whole patient story, not just from words, but from everything, the little cues, the numbers, what you see, sort of like being a medical detective, right? Putting it all together. So today we're unpacking exactly that skill, the art, and definitely the science of patient assessment. We're really diving deep into the health history and the physical exam using insights from core nursing text. The goal here is for you, our future nursing leaders, to really get a solid grip on this. We want you to move past just, collecting data towards making those really smart, confident clinical judgments. We'll break down the what, the why, and definitely the how of it all.
Absolutely. And that's so crucial because assessment isn't just like a task you check off a list. It's not a one-time thing. It's this continuous, really dynamic process. Think of it as the absolute foundation for the whole nursing process. I mean, without a good assessment, everything that follows planning, intervening, evaluating, it just doesn't stand up. It's how you build that essential baseline. That's what lets you spot those subtle, sometimes tiny, but critical changes in your patient later on.
Okay, let's make this real. Let's picture a patient. Let's call him Mr. David Thompson. He's 68, comes into the ED chest pain, short of breath. Acute, he looks anxious, maybe a bit pale, definitely uncomfortable. The second you see Mr. Thompson, your assessment kicks in instantly. So when we talk about assessment here, we mean that hands-on systematic collection of data. And the database, that's literally everything you gather about Mr. Thompson, all of it. It creates his complete clinical picture.
Yeah, and what's really interesting is seeing how your nursing assessment slots into the bigger picture, the whole healthcare team. You're part of this interprofessional group, doctors, therapists, specialists, everyone working together. And while everyone adds to Mr. Thompson's shared database, your nursing assessment brings a really unique, vital perspective.
Mhm.
It's not just about figuring out the disease, it's about understanding Mr. Thompson's experience with that disease. How is it affecting him?
That's such a key difference, isn't it? Because a physician or maybe an APN that's an advanced practice nurse, a nurse with extra education and experience, they'll focus their history and exam on nailing the medical diagnosis. Is it a heart attack?
Mm,
Pneumonia?
right, the medical piece.
But the nurse, we're looking at something else just as critical. Our focus is diagnosing and treating the human responses to those health problems, whether they're actual problems right now or potential ones down the line.
Mm.
So back to Mr. Thompson. The APN might be ordering an ECG, checking labs to diagnose, say, an acute MI, a heart attack. That's the medical focus.
Mhm.
But you, as his nurse, you're using that same info, plus your own observations, to figure out his pain level right now, his anxiety, how easily he's breathing, and maybe thinking ahead about how this whole event might impact his life, his independence. You're assessing how his body, his mind, his whole being is responding to that MI. That's the nursing difference.
And to get that full, rich picture, you need two basic kinds of data, subjective and objective. So let's think about Mr. Thompson again. What specifically are you looking for?
Exactly. Okay, so subjective data, we often call these symptoms. This is what Mr. Thompson tells you. It's his personal account, his experience. Only he could describe it. So when he says, it feels like an elephant is sitting on my chest or I'm really scared, that's subjective, purely from him.
Got it.
His words.
Then there's objective data. These are the signs. This is the stuff you can actually see, measure, touch, or get from tests.
Observable stuff. Right. His vital signs, pulse, BP, respiratory rate, the paleness you see on his skin, the clammy feeling when you touch his arm, maybe crackles you hear in his lungs with your stethoscope. You gather this using your senses, your tools.
Okay. And when you have both types of data, the subjective, what he says, and the objective, what you find, and they both point towards a specific problem,
Yeah.
that's when we call them clinical manifestations. They're the evidence, really, like Mr. Thompson's chest pain description, plus maybe his EKG changes or elevated cardiac enzymes, both manifesting that cardiac issue.
Okay, so now we know what we're after, subjective and objective data. How do we actually get Mr. Thompson's story, the subjective part? Well, that mostly happens through the patient interview. That's where you get the nursing history. And it's so much more than just ticking boxes on a form. It's really a chance to connect, to build trust, to really listen. The aim is to get that holistic view, his health, past and present, how he sees things, what worries him.
And this is where communication is just everything. You absolutely have to create the safe space, trust, respect, acceptance. With Mr. Thompson, who's obviously scared and hurting, that means being open, calm, completely non-judgmental. What you say matters, sure, but your nonverbals, eye contact, posture, just being present, they often say even more.
definitely. And you've got to be aware of cultural factors too, right? Different cultures have different ways of sharing information, different comfort levels with eye contact, even different ways of showing pain.
Mm-hmm.
You need to be sensitive to that.
Spot on. It means your communication style has to be flexible, adaptable, because every patient, like Mr. Thompson, is different, and the time it takes, it varies hugely. Mr. Thompson, right now, in acute distress, he's not going to sit through a super long, detailed history. You have to prioritize what's most important immediately.
Yeah, absolutely.
And you also have to think about reliability. Sometimes factors like acute pain, anxiety, like Mr. Thompson's situation, or maybe confusion in an older adult can affect how accurately they recall things. You have to sort of gauge that as you go.
Which brings up a really critical point, something I think students sometimes find tricky. You might have your checklist of questions, but you always have to address the patient's immediate needs first. Mr. Thompson's priority. If he's grabbing his chest, wincing, telling you the pain is a 9 out of 10, asking about his childhood mumps is not the first step.
No, definitely not.
Your first job is to help manage that pain, get him some relief. Once that urgent issue is handled, he'll be much more capable and probably more willing to give you the other details you need.
Makes perfect sense. Address the fire first.
Okay, so let's say you've given Mr. Thompson something for his pain, maybe some oxygen, he's feeling a little bit better, but the chest discomfort is still there. Now you need to dig into that symptom systematically. And this is where a great tool comes in the PQRST mnemonic. It's just invaluable, a really structured way to explore any symptom a patient reports.
Ah, yes. PQRST. Super useful.
Let's walk through it with Mr. Thompson's chest pain. P is for precipitating and palliative. What brought it on? What makes it better or worse? He might tell you, well, it started when I was out raking leaves, and it eased up a bit after that little pill you put under my tongue. Nitroglycerin.
Okay.
Q is for quality. What does the pain feel like? He describes it as like a heavyweight squeezing.
Good description. Specific.
R is for radiation. Does it stay put or travel? He might say, yeah, it goes into my left arm and kind of up into my jaw.
Classic signs.
S is for severity, usually the 0 to 10 scale. You ask him now, after the initial intervention, he says, maybe a 5 now. It was definitely a 9 before.
Shows improvement. Important.
And T is for timing. When did it start? How long has it been going on? Is it constant or does it come and go? He tells you, it started about 2 hours ago, was constant, and really got bad in the last half hour before I came in.
Wow. See how using PQRST just takes that vague chest pain and turns it into such a detailed, clinically useful picture. Just a few focused questions. It's systematic.
Exactly. Gives you so much to work with.
So once you've gathered all this subjective info from Mr. Thompson, you need a way to organize it, right? Some places use forms based on body systems, but those can sometimes, miss things like how the patient's coping or their health habits. That's why a framework like Gordon's functional health patterns is often really helpful. It provides this comprehensive structure, looks at 11 different areas of health or function. It helps make sure you cover all the bases for someone like Mr. Thompson, thinking about his whole life, not just his heart.
Right, more holistic.
Let's touch on a couple that seem really relevant for Mr. Thompson. The health perception, health management pattern is huge. You'd ask him how he sees his own health generally. Does he do preventative stuff, checkups, vaccines? What about family history, especially heart disease for him? And a big one, what does he expect from being in the hospital? You might find out he's been having little symptoms for weeks but ignoring them.
That's really insightful.
And another key one for him would be the activity-exercise pattern. What's his normal routine like? Work, hobbies, exercise. And crucially, how's his ability to do his activities of daily living ADLs? Bathing, dressing, getting around. Is this chest pain and shortness of breath limiting him now? Maybe he was fully independent before level 0, but now he needs help. Moving towards level 1 or 3, you need to assess that functional impact.
And thinking about his anxiety, his pain, the cognitive perceptual pattern seems really important too. Does he have any hearing or vision issues? How's the pain affecting his thinking? How does he learn best? And maybe most importantly right now, what does he actually understand about what's happening to him and the plan? This helps you tailor your education later when he's recovering. It's about seeing him as a whole person.
Absolutely. Beyond those patterns, there's other vital subjective stuff you need to get.
Oh yeah, definitely. Like a good health history, any major illnesses as a kid or adult, significant injuries, previous hospital stays, surgeries. You need the when and why for those. And medications. This one is massive. You need to know everything Mr. Thompson takes. Prescription meds, obviously.
Yeah.
But also over-the-counters, any recreational drug use, vitamins, and especially herbs and dietary supplements.
Oh, that last category is so often missed.
Right. Patients often don't think of them as real medicine, but they can cause serious interactions, particularly with heart medications. And for older folks like Mr. Thompson or anyone with chronic conditions, you're also looking out for polypharmacy taking too many drugs, and if cost is making it hard for him to take them regularly.
And allergies, of course. Non-negotiable safety check. Not just drugs, think latex, contrast dye for tests, food, environmentals, but don't just list the allergy. You need to know what kind of reaction he had. Was it just a mild rash? Or was it trouble breathing, anaphylaxis? Big difference in how you manage it.
Critical difference.
And finally, get details on past surgery and other treatments. Dates, reasons, outcomes. Did he get blood products? Knowing his history helps anticipate current needs or potential issues.
Okay, phew. That's a lot on the subjective side, what Mr. Thompson tells you. Now let's flip the coin. Let's talk about the objective data, what you find through the physical exam. This really starts the moment you see him, with your general survey. Think of it as your initial scan, your first impression, but it's more than that. It's a deliberate observation that continues the whole time you're interacting.
That false look tells you so much.
For Mr. Thompson, your general survey would capture things like his overall appearance, his obvious anxiety, maybe his speech is rapid or strained, he might be restless. You'd note the pale, clammy skin we mentioned. You'd also get his vital signs right away, maybe estimate his BMI. All of this, before you even lay hands on him, gives you a really valuable snapshot. It sets the stage for your more focused exam.
That general survey gives you immediate context, absolutely. Then you dive into the core physical examination techniques. There are 4 main ones, and usually you do them in a specific order. Inspection, then palpation, then percussion, and finally auscultation.
Okay, inspection, palpation, percussion, auscultation. Got it.
But, and this is a big but, you absolutely have to remember the abdominal exam is different. For the abdomen, the order is inspection first, then auscultation, then percussion, and palpation last.
Ah, right. Auscultation before touching. Why is that again?
Because if you palpate or percuss the belly first, you can actually stir up bowel activity. That changes the sounds you hear when you listen with your stethoscope, potentially giving you a misleading picture of what's really going on.
Okay, that makes sense. Listen before you poke around.
Exactly. So let's quickly run through what each technique involves. Inspection is just looking. Careful, systematic visual assessment. You're deliberate, you compare one side of the body to the other for symmetry, you look for anything unusual. For Mr. Thompson, you'd inspect his skin color, watch his chest rise and fall with breathing, is it even? Look for any visible pulsations on his neck or chest. Even something subtle, like noticing maybe an older patient doesn't have much hair on their lower legs, could just be age, or it could be a clue about their circulation, peripheral vascular disease.
Huh, interesting example. Simple observation, potentially big implications. Okay, next is palpation.
Right. Palpation is using touch. You use light or deeper pressure to feel for things like masses, pulsations, tenderness, swelling, skin temperature, muscle tension, even texture. You use different parts of your hand for different things. The back of your hand, the dorsa, is best for temperature. Your fingertips are more sensitive for feeling pulses, like Mr. Thompson's radial pulse, or pinpointing tender spots on his chest.
Okay, touching with purpose. Then percussion. That's the tapping one, right?
That's the one. You gently tap on the skin, usually with your fingers, to create vibrations and sounds from the tissues underneath. The sound tells you about the density. You expect a resonant sound over healthy, air-filled lungs. Dullness might suggest a solid organ like the liver, or maybe fluid where there shouldn't be, like fluid in Mr. Thompson's lungs, perhaps. Flat sounds are over bone or very dense muscle.
So the sound gives you clues about what's underneath. And the last one, auscultation.
Auscultation is listening, usually with your stethoscope. You listen to heart sounds, breath sounds, bowel sounds. The bell of the stethoscope is better for low-pitched sounds, like certain heart murmurs. The diaphragm is better for high-pitched sounds, like normal breath sounds or bowel sounds. And remember, position matters. For heart sounds especially, you might listen while Mr. Thompson is sitting up, lying flat, or rolled onto his left side to hear different things more clearly.
Right, positioning can bring out certain sounds. And before you even start all this, you need your tools ready, yeah.
Oh, absolutely. Your equipment, have your stethoscope, BP cuff, pen light, maybe a reflex hammer, an eye chart nearby. It just makes things smoother, shows you're prepared, which can actually help Mr. Thompson feel a bit more at ease, too.
Good point. Professionalism matters.
And when you're actually doing the exam on Mr. Thompson, organization is key. A systematic approach, usually head to toe, keeps you efficient and helps make sure you don't miss anything. Always tell him what you're about to do. Make sure he's as comfortable as possible, maintain his privacy and dignity. And afterwards, documentation. You have to clearly record everything you found normal and abnormal in his chart.
And you mentioned earlier, sometimes you need to adapt for older adults, like Mr. Thompson.
Exactly. Simple things like keeping the room warm, maybe they need help changing position because of arthritis or weakness, speaking clearly in a quiet room if they have hearing loss, being gentle, just tailoring your approach.
Okay, so we've covered the what's subjective, objective data, and the how, the interview, the exam techniques. But here's where it gets really practical. You don't do the exact same assessment every single time, right?
Not at all. Your approach has to fit the situation.
Our source points out three main types: emergency, comprehensive, and focused assessment. An emergency assessment is pretty self-explanatory. It's fast, it's targeted, and it happens in life-threatening situations.
Yeah.
When Mr. Thompson first hit the ED doors, gasping, clutching his chest, that's prime time for an emergency assessment. Your absolute priority is the ABCD's airway, breathing, circulation, disability. Is his airway clear? Is he breathing okay? Is his heart pumping effectively? Is there any sudden neurological change? Speed is critical here. ED, ICU. That's where you see this most.
Right. Immediate life threats first.
Then, once Mr. Thompson is more stable, maybe he gets admitted to a cardiac unit. That's when you typically perform a comprehensive assessment. This is the deep dive, detailed health history covering everything, plus a thorough physical exam of all body systems, head to toe. It establishes that complete baseline we talked about. You do this on admission to the hospital or maybe the first visit in primary care.
That big picture look.
And finally, there's the focused assessment. This is shorter, more targeted. It zooms in on one or maybe a couple of body systems that are related to a specific problem or concern. So for Mr. Thompson, admitted with that cardiac issue, you'll be doing focused cardiovascular and respiratory assessments regularly, probably every shift. If a day later he complains of new belly pain, boom, that triggers a focused abdominal assessment.
Exactly. You use focus assessments throughout the hospital stay, at the start of your shift, to check on known issues, or anytime something new crops up. It's about monitoring and managing specific problems.
Okay, let's trace Mr. Thompson's journey with these assessment types.
Yeah, good idea. So he arrives in the ED, severe respiratory distress, first thing. Emergency assessment ABCDs, get him stabilized. Once he's a bit better, maybe on oxygen, getting some meds, you do a focus assessment of his respiratory and cardiovascular systems to get more detail on the immediate problem.
Okay.
He gets admitted to the unit. Within the required time frame, you perform the full comprehensive assessment, get that complete baseline. Then, every shift starts with a focused assessment, checking his heart, his lungs, things related to his diagnosis, maybe heart failure now. And let's say on day 2, you listen to his lungs and hear new crackles that weren't there before.
Oh.
Right. That triggers another focused assessment. You'll listen carefully to his lungs again, maybe check his JVD, edema, weight, focusing on signs of worsening heart failure, maybe involving both respiratory and cardiovascular systems because they're so linked. It's truly dynamic.
Wow. That really illustrates how you shift between these assessment types based on the patient's needs. What an amazing overview of assessment. So just to quickly recap the big takeaways for everyone listening. Remember how vital that systematic approach is for both the interview and the physical exam. Keep subjective and objective data clear in your mind what the patient says versus what you find. That PQRST mnemonic. Seriously, use it. It will make your symptom investigation so much better. Frameworks like Gordon's functional health patterns help you see the whole person. And mastering those exam techniques, inspection, palpation, percussion, auscultation, remembering that abdominal exception, sharpens your clinical skills immensely. And finally, knowing when to pull out the emergency, comprehensive, or focused assessment ensures your care is timely and appropriate, just like we saw with Mr. Thompson.
And here's something to really think about as you move forward. As nurses, yeah, we collect a ton of data, but the real skill, the true art of assessment, isn't just knowing the what, it's figuring out the so what. How does every single piece of information you gather, Mr. Thompson's fear, his lung sounds, his lab value, how does that directly shape your very next action, your clinical decisions, and ultimately, how does it impact his outcome? That's the question that takes you from just collecting data to being a truly skilled clinician.
That is a powerful thought. Definitely something to mull over. We really hope you'll take these ideas, reflect on them, and start weaving them into your practice and your studies. The more you connect these dots, the better your assessments will become. Thank you so much for joining us on this deep dive. From the entire team here, we really appreciate you tuning in.